Let's take a look at a practice problem. So AF is a 45-year-old white female who was admitted to Loma Linda University Medical Center General Ward with a Streptococcus viridans endocarditis, and she has native heart valves. She's allergic to penicillins and cephalosporins. Her current serum creatinine is 2.4 milligram per deciliter, and it is stable. The medical team would like to start vancomycin and ask you for a vancomycin recommendation based on the 2015 American Heart Association guidelines for infective endocarditis in adults. So let's take a look at a few important information here. So first of all, this is a 45. The age is 45 years. It is a female. The height is 5'2". Weight is 140 kilogram. And the infection is Streptococcus viridans endocarditis. We need serum creatinine 2.4, which is stable. And they are asking for specific guideline recommendations. So 2015 American Heart Association. Now, before we get to vancomycin dosing, let's do the basics first. So essentially, this patient's ideal body weight would be 45.5 because it's a female, plus 2.3 times 2 inches over 5 feet tall, which would give you 50 kilograms. So that's the ideal body weight. Next, we look at total body weight. In this case, it's easy because it's not in pounds, so we don't have to convert. So it's already given to us 140 kilogram. Now that's significantly higher than the ideal body weight. So let's, if you calculate the BMI, the BMI would actually get 56.4. So, she is definitely obese. And you don't necessarily have to calculate BMI, but if you get the ratio of total body weight to ideal body weight is definitely more than 30%. So we are going to, so this is more than 30% of ideal body weight. So we are going to calculate adjusted body weight, which is essentially the ideal body weight plus 40% of the difference between ideal body weight and total body weight. So total body weight is 140 kilos minus 50, which would give you 86 kilogram as adjusted body weight. And of course, for vancomycin, we always use total body weight when it comes to dosing. And the reason we're calculating adjusted body weight is literally for the purpose of calculating creatinine clearance. So just to assess the kidney function, we would calculate creatinine clearance using adjusted body weight. So it's 140 minus the age, which is 45 years. Times the adjusted body weight, which is 86 kilos, and that's divided by 72 times serum creatinine, which is 2.4, and because this is a female, we multiply by the female factor 0.85, which will give you 39.7 ml per minute. And you can actually round this to 40 ml per minute. Okay, so we got the basics down. Next, we need to know how to actually dose vancomycin based on 2015 American Heart Association guidelines. So if you go to PubMed and essentially just type the first author, so the author's last name is given to you here, Badur, and then the journal name, circulation, and the year of publication. That's a good starting point. So if you just search here, you will see that there are 3 top results. I mean, of course, there are more results down there, but you will see that the third entry is the author's name and the journal name, and this is the guideline that you're looking for. So if you click this, it will take you to the page for the guideline, and then you can click on the journal's link to go to the journal. So if you click this, it will take you to Circulation, which is American Heart Association's journal, and they do publish American Heart Association guidelines in this journal. The latest endocarditis guideline was published in 2015. It has not been updated since then as of this recording. So here, if you want, you can download the PDF. It should be free access, so you should be able to get that even if you don't have access to the library. Now, for the way these guidelines are organized is based on the nature of the valve as well as the organism. So first we are going to look for the organism, and this is a Viridin strep. So if you kind of navigate this guideline, you will find out that the VGS stands for Viridin group streptococci. So we're going to go to this section. So if you scroll down, there's a whole section for this. And if you go down, now the next thing is for each organism group, they either have recommendations for native heart valve versus prosthetic valve. This patient has native valve, so this is actually the correct section. So you will see they have nicely, they have placed the recommendation nicely in a table. For this, we don't have to essentially figure out what the treatment is because the team has already committed to vancomycin. We're just trying to find the dose. So if you go down to vancomycin, you will see that the guideline recommends 30 milligram per kilo per 24 hours divided equally into 2. So essentially that would translate into 15 milligram per kilo every 12 hours. Of course, that's for someone with normal renal function. So now we're gonna see what to do for this patient. And then they also tell you that vancomycin therapy is reasonable only for patients unable to tolerate penicillin or ceftriaxone, which sounds like this patient who has allergies to penicillins and cephalosporins. And vancomycin dose should be adjusted to a trough a range of 10 to 15. Okay, so now let's see what we can do for this patient. So, so we essentially found out. Let me switch to a pen. So essentially 30 milligram per kilogram per 24 hours divided in 2, right? So divided in 2. Okay, so essentially that would mean 15 milligram per kilogram Q12 hours, right? Now, that's normal renal function. This patient's renal function is creatinine clearance, but creatinine clearance equals 40. So if you remember from the lecture, if creatinine clearance is 15 to 49, or you can use something like Lexicomp for renal adjustment. So for creatinine clearance between 15 to 49, we essentially use Q24 hours. Okay, so instead of 15 milligram per kilo every 12 hours, we are going to dose adjust to 15 milligram per kilo every 24 hours for this patient. Now, remember, you have to use total body weight when calculating dose for vancomycin. So this is 15 milligram per kilogram times total body weight, which for this patient is 140 kilos. Which would give you 2,100 milligram. For vancomycin, we round every 250 milligrams. So, we can round this down a little bit to 2,000 milligram. We are rounding down instead of up because, this patient is obese, and we know that when you go over 2 grams of a single dose, you increase the risk of nephrotoxicity. So for that reason, I'm going to round down to 2000 milligram or 2 grams. Let's see. So the final recommendation for this patient would be so vancomycin, 2 grams IV every 24 hours, and this will be infused over at least 2 hours because it's 2 grams, starting immediately. So that's it for problem number 1. Let's go to problem number 2. So problem number 2 is DG is a 66-year-old female with an MRSA sternal osteomyelitis secondary to coronary artery bypass graft or cabbage surgery. Her current serum creatinine is 1.4 and it is stable. The medical team asks you to recommend a PK/PD optimized vancomycin regimen using population pharmacokinetics. Now, this hospital targets a serum vancomycin trough of 10 to 15 for non-severe infection and trough of 15 to 20 for severe infection. So again, the important information is the age. This is a female, height, weight. This is a MRSA osteomyelitis, so this is a severe infection. So we want to go for 15 to 20 per, this hospital's protocol. I'm not saying that 15 to 20 is the right target for this infection, but if the hospital has a protocol for this type of goal for trough, then that's what we are doing for this problem. So again, let's do the basics first. For this patient, the weight is given in pounds, so we need to convert it to kilograms. So total body weight is 143 pounds divided by 2.2, which will give you 65 kilos. So 65 kilograms, that's total body weight. And then for ideal body weight, again, this is a female, so 45.5 plus 2.3 times, this is 5 inches over 5 feet tall, which would give you 57 kilogram. Okay, now if you get the ratio of these two, so essential total body weight is 65 divided by 57 would give you 1.14. So that means this total body weight is only 14% above ideal body weight. So there is no need to calculate adjusted body weight. Okay, and for the purposes of renal assessment, we're going to use the ideal body weight. Okay, but for vancomycin calculations, including dosing or other things directly related to vancomycin, we will use total body weight. But for using Cockcroft-Gault to calculate creatinine clearance, we're going to use ideal body weight. So again, this is 140 minus age, which is a 66-year-old female, times the body weight is 57, and divided by 72 times the serum creatinine, which is 1.4. And again, this is a female, so multiplied by female factor 0.85, and this would give you 36 milliliters per minute. Okay, now let's do calculations for vancomycin. Specifically, we're going to use population kinetics because specifically this question is asking us for PK/PD optimized vancomycin dosing. So a good starting point is to get vancomycin clearance, which is essentially one way to do it is 0.8 times creatinine clearance. So this is times 36, and because 36 is milliliters per minute, we multiply by 0.06 to convert it to liters per hour, and this will give you 1.7 liters per hour. That's vancomycin clearance. Next, we can do Let's see, we can do volume of distribution for vancomycin. Now, nothing in this problem indicated that the patient is either dehydrated or has fluid retention, so we're going to use the average of 0.7 times total body weight. So this is, again, total body weight. Make sure you use the correct weight. So this is 0.7 times 65 would give you 46 liters. So this is volume of distribution. And then next we can do the elimination constant. So there are different ways to calculate elimination constant. One way is to actually use clearance and volume of distribution. So here's clearance divided by volume of distribution. So we calculated clearance to be 1.7. Divided by volume of distribution, which was 46. And this would give you 0.037 inverse hours. Okay, so that's one way to do it. Another way is to use the Motzky equation. So that would essentially give you the equation 0.00083 times creatinine clearance, which is 36 milliliters per minute, plus 0.0044, and this will give you a K of 0.034. So it's pretty close. Now, a small deviation in K can be a little more when you convert it to half-life. So let's see, if you calculate the half-life based on this, so essentially ln of 2 divided by K. So this will give you about 20.4 hours. Using the original K we found, if you calculate half-life, this will give you essentially 18.7 hours. So, you know, a couple hours difference, but not something that would be significantly different. You know, ultimately, regardless of which K you calculate, you should end up with the final answer that's pretty close, and I will show you the differences. But let's go with the original K that we calculated. It doesn't matter which one you choose, because both of these are estimation. Okay, so at the end of the day, probably neither of them are the true K, because we are using the population kinetics. So these are estimates from population. You know, the true K in this patient will not be known until we actually get levels from the patient and we calculate the K. Okay, right now we are just guessing. So let's continue guessing using population kinetics. So the next thing we want to do is we're going to calculate tau. So in this case, because this is severe infection and the hospital wanted us to target a 15 to 20 trough, I'm going to pick a goal peak of 40. You know, again, this doesn't matter what you choose as the peak. You know, it just needs to be something reasonable so our math checks out. But for the trough goal, I'm going to pick something between 15 and 20. So I'm just going to choose 17 for this case. And then divided by K. So I'm using the blue K here, 0.037. And that will give you a tau of about 23 hours. Which I'm going to round to 24 hours. So I'm going to use 24-hour dosing for this patient. You know, you want to use something that's clinically reasonable. Next, we're going to calculate the dose based on this. So the dose would be essentially your K times volume of distribution, which is 46, times the goal peak, which is 40, times 1 minus e to the negative k times the tau, which is 24 hours in this case. And then in the denominator, we have 1 minus e to the negative k, and time of infusion, we'll just assume 1 for now. And this will give you a dose of about 1103 milligram. So you can either round this up or down, right? So because this is not unusually high, so I don't have concern for nephrotoxicity. So you can either do 1000 milligram or perhaps 1250. Okay, so we're gonna test and see which one would be the correct or more likely to give us the results we want. Okay, so I'm going to test 1000 milligram every 24 hours. And this is nice because it's 1000 milligram. We infuse it over 1 hour, so it will make the math easier. So I'm going to start with this. And if it doesn't work out, then I can go and test 1250 milligram. Because if you do the 1250 milligram first, your time of infusion would have to be 1.5 hours. That's going to make the math more complicated. So, I'm going to start with this one first, and hopefully it will work out. So if you do, I want to see what would be the predicted peak using this regimen. So it would be 1000 milligram divided by time of infusion, which is 1. That's nice. Times 1 minus e to the negative k times time of infusion, which again is 1. And then in the denominator, we will have the volume of distribution, which is 46, times our k. Again, I'm using the blue k. And times 1 minus e to the negative k times tau, which is 24 hours. And this will give us a predicted peak of 36.3. Now we don't have a target peak, because we are, for efficacy and safety, we are really targeting the trough for vancomycin, so it doesn't really matter if we got 40 or 50 or 30 for the peak. We just want to make sure that we get the right trough. So predicted trough would be your peak, your predicted peak, times e to the negative k times your tau minus time of infusion. So 24 minus 1. And when you plug this in, it will give you a trough of 15.5. And we wanted the trough to be 15 to 20, so this is good, right? So we can go ahead and recommend. But actually, before we recommend, we also want to make sure that while this gives you the right trough, you want to make sure that you're getting the right AUC as well. So when calculating AUC, use the trapezoidal rule equation. So this is essentially you say your peak, which predicted peak, which is 36.3. Plus predicted trough, which is 15.5. That's divided by 2. And this whole thing will multiply it by time of infusion, which is 1 in this case. And that's plus, now the difference between peak and trough, which is 36.3 minus 15.5. And this is divided by your k. And then you multiply it by, essentially 24 minus your tau. In this case, tau is 24, so you only get one peak. So that makes the math a little easier. So this will give you 588 as predicted AUC. I didn't put units here, but make sure you also include your units in your answers. But essentially, you wanted peak and trough, I'm sorry, the AUC to be somewhere between 400 to 600. Okay. Now, if it goes less than 400, it's less likely to be effective. Now, if it goes above 600, it's gonna get toxic once you approach 700. So if you're a little above 600, these are predictions, so it doesn't necessarily mean that it will be like 650 if you calculate it. But you know, as long as it's under 700, you should be fine. And so since the AUC and trough are what we want, you can go ahead and recommend vancomycin 1000 milligram IV infused over 1 hour, starting now. Now, what would have happened if you had carried on with the other method of calculating K? So let's see what would happen. So if we had gone with Motzke equation, you would have had a slightly different K. So here's the green K, 0.034 instead of 0.037. So essentially, if you go this route, I'm going to use green ink just to show you. If you were to calculate the dose, so with this K, you will get, you know, so everything will be the same. You just use a different K. So the dose here would be about 1044 milligram. Okay, so that's different than 1103. But then again, we round every 250 milligrams. So again, your options are here, either 1000 milligram or 1250 milligram. And for your tau, if you were to use calculate tau using the green K, you would end up with, instead of 23 hours, you would end up with 25 hours. Okay, which again, we round to something that's clinically reasonable, so we're going to use Q24 hours anyway. So you see, regardless of which K you use, we will come up with the same you know, possible answers. But then when you calculate predicted peak and trough, you will also have some differences. So if you were to test 1000 milligram every 24 hours using the green peak, you essentially would end up with a predicted peak of 38.3. And if you do the predicted trough, you would end up with 17.5, which is still within the goal of 15 to 20. So essentially, the answer wouldn't have changed much regardless of which K you would have used. Now, if you had tested you know, the other possible dose, so let's say you want to do 1250 milligram every 24 hours over 1.5 hours. Okay, now let's do it with the original blue K. So if you were to do this, your predicted peak would essentially be something around 44.9, and your predicted trough would have been 19.5, which is again within your target of 15 to 20, but these are estimates and this is kind of like borderline. Okay, so this is where depending on which K you use, it will likely make a difference. So if you do the same thing with the green K, your predicted peak would be essentially 47.5, and your predicted trough using the green K using Motzke equation would be 22.1, which is toxic. Okay, so for that reason, I will, you know, I know one K is giving you within range, but the other K is giving you potentially toxic trough. And these are all estimates, so we don't know which one would actually end up happening in the patient. So for that reason, I will not be recommending this empirically, and I will go with, you know, 1000 milligram every 24 hours. Now, let's move on to the second part of this problem. So this is essentially the medical team accepted your vancomycin recommendation from part 1. Now, it's 2 days later, and the patient is clinically improving. Serum creatinine continues to be 1.4, and now we do have a single vancomycin level, so just one level 30 minutes prior to the next dose, and it happens to be 22. Now 30 minutes is pretty close to the trough, so it's not really worth calculating what would it be 30 minutes. It's fair to say that, you know, if on a 24-hour dosing interval, if it has been, you know, 23.5 hours since the dose was given and the level is 22, you know, I don't think 30 more minutes is gonna go down below 20. So it's fair to assume that this is a toxic trough. Now let's do some calculations, because the medical team asks you to adjust the vancomycin dose based on the vancomycin level. So the first thing you want to do is update some of the numbers based on the level we got. So what we cannot change is the volume of distribution, and you know, we only have a single level, so we still have to use the population PK volume of distribution that we calculated in the previous part. So volume of distribution would still be 46 liters, which we calculated previously. Now what we can do is extrapolate from this 22 and see what our peak is. So the peak, and that's essentially because we recommended 1000 milligram every 24 hours over 1 hour. Okay, so we can estimate what the peak would be in this patient, because we use 1000 milligram, and the volume of distribution we guessed or estimated that it would be 46 from pop PK, and then plus the trough, which is you know, approximately 22, and that will give you an estimated peak of 43.7. So the units would be milligram per liter. Okay, and then we can calculate a new K. So in the previous part, our K was completely from population kinetics. Now this is like semi-population kinetics, because this 46 still coming from PK, but this 22 is coming from the patient. So this is an improved, we're gonna have an improved K, because we're gonna use this to calculate a new K. Okay, so this is essentially ln of peak, which is 43.7 divided by the trough, which is 22, and the time between two levels, right? So if our tau was 24 hours, so overall 24 hours, it was infused over 1 hour, so our peak is 1 hour later, so we're going to subtract 1. And this 22 is also 30 minutes before the next dose, so we are going to subtract another 0.5 here. So the time between these two levels is essentially 22.5. Okay, and that will give you a new K of 0.031 inverse hours. And of course, anytime you have a K, calculate a half-life, which will give you, this is 22 hours. Okay, the half-life helps you kind of estimate when the steady state will be achieved. So when you want to order your levels, you know, you will use the half-life. So since we have a new K now, which is 0.031, we are going to calculate another regimen, so new tau. Again, we're gonna do ln of our goal peak and trough, so that hasn't changed. It's a severe infection, so 40 over 17. Again, 17, I just chose something between 15 to 20. It's a good idea to go in the middle, so you don't, you know, because these are estimates, so if you go for 15, you might end up for, you know, under 15, or if you go for 20, you might end up over 20. But if you choose 17 and if you go under or over, you might still be within range. And that's divided by the new K. Okay, so use this new K. And that will give you a new tau of 27.6. Okay, now you can do two things here. we can either, use the Q24 hours that we had before, or you might say that, well, 24 hours was not enough for the body to clear vancomycin, so we ended up with a toxic trough of 22. So maybe when the body needs more time, so maybe I will round up to the next clinically reasonable frequency would be every 36 hours. Okay, so we're not going to choose random time. So the standard is like every 6 hours, every 8 hours, every 12 hours, every 24 hours, every 36 hours, every 48 hours, and so on. So we have two options here, but now let's calculate a new dose. So new dose. Again, the same equation as before, but the new K, okay? So K times volume of distribution, still 46, times the peak that we want, times 1 minus E. I'm gonna go with the 24 hours first because, maybe we need a smaller dose that goes with it and see what happens. If it doesn't work out, then I'm going to try every 36 hours. So 1 minus E to the negative K times 24. And then in the denominator, you will have 1 minus E to the negative K times time of infusion is 1. And this will give you a new dose of 980 milligram. Which you can round to 1000 milligram, right? But this is where you would stop, because 1000 milligram every 24 hours is exactly what this patient had, and it resulted in toxic trough. So you do not want to use 1000 milligram. Now another option would be to use 750 milligram and see if that works. This would be every 24 hours. But I'm also going to explore every 36 hours. So let's see what would it be if we do tau of 36. So the new dose, again, K times 46 times 40, 1 minus E to the negative K times 36. And denominator would be the same, 1 minus E to the negative K times 1, and this will give you 1256, which we can round to 1250. Okay, so even though the dose is higher than what we had given the patient, but the interval is longer, so the body has more time to clear it. So we can test this to see what happens. Now, one thing I forgot to calculate when we got our new peak is to see, based on the previous regimen, what was the AUC, right? So if we calculate what AUC the patient had achieved, the peak is 43.7 plus the trough, which is 22 divided by 2, and this is times the time of infusion, which is 1, and then you say plus the difference between peak and trough, 43.7 minus 22, and that's divided by K, which is the new K, 0.031, and all of this you multiply by 24 divided by tau, which was 24 here, and this will give you an AUC of 732. So this is also toxic. Okay, so it matches. We had a trough, that's 22, everything is toxic, it's supratherapeutic, and we have an AUC that agrees that the dose 1000 milligram every 24 hours is toxic. Now let's continue, go back and test the 1250 milligram every 36 hours. So test 1250 milligram every 36 hours, and this will be over 1.5 hours. Okay, so we're going to test this to see what we get for our predicted peak and trough. So predicted peak would be, so you know, 1250 divided by 1.5, and this is times 1 minus e to the negative k times 1.5, and in the denominator we'll have 46 times k times 1 minus e to the negative k times tau is 36, and that will give us a predicted peak of 39.5 and predicted trough is predicted peak 39.5 times e to the negative k times your tau, which is 36, minus time of infusion, which is 1.5, and that will give us 13.6. So this did not work because we wanted it to be 15 to 20, so that didn't work. Okay, so we cannot recommend 1250 every 36 hours. So what we can do is that I can say, okay, so if this dose didn't work, what I can do is to essentially try a higher dose. So let's, I'm gonna do it over here. So let's test instead 1500 milligram because we round every 250. So 1500 milligram every 36 hours, still over 1.5 hours. Okay, so we're going to test this. Predicted peak when you do this would be essentially 47.4, and predicted trough would be 16.3. Now this is what we wanted because we wanted it to be 15 to 20. Okay, now before we actually recommend this, let's also test what the AUC would be. So AUC, predicted AUC would be, so we're gonna use these two numbers. Okay, so this is 47.4 plus 16.3. This is divided by 2, and this is times time of infusion, which is 1.5, and then we add the difference of peak and trough, 47.4 minus 16.3 divided by k, and then times, this part is important because it's 24 divided by tau. If we're using tau of 36, we're actually reducing the AUC for 1 day. Okay, so for a 24-hour period, and this will give you exactly 700. Okay, now this is borderline and these are estimates, so there's a good chance that this will actually be lower. You know, so as long as it's not over 700, I'm not too concerned, given that this is a big estimate. So this is what I would recommend, the 1500 milligram every 36 hours. Okay, now you could, I didn't explore what the 750 every 24 hours would do. You can explore and see if that gives you a better answer. If so, then that would be a better recommendation, but I'm happy with the numbers right now. So 1500 milligram every 36 hours over 1.5 hours is what I recommend. But we're not done because we need to figure out when to give the next dose, because the trough that we had is toxic. So we don't want to just give the next dose right now while the patient's vancomycin levels are in toxic levels. So you do want to calculate when to do that. So when to give next dose. So you can use the equation, C2 equals C1 times e to the negative kt. Okay, so there are different ways to do this. For example, let's say, right now the initial concentration is 22, that's the trough, and you want to see how long it would, given that we know the k, we're interested in t, how long would it take for the level to go from 22 to, you can definitely want it to go to less than 20. Just to be safe, I'm going to say, I'm going to use 17, for example, because 17 is between 15 to 20, right? So you don't want it to go less than 15 for this patient, and you don't want it to be more than 20 because it's toxic. So I'm just going to put, these are estimates, so I'm just going to go for 17 and see how long it would take. And when you rearrange this, essentially, you would say t equals negative ln of 17 over 22 divided by your k, which will give you 8 hours. Okay, so that's the key here. It will take 8 hours for the trough to go from 22 to 17. Now, if you wanted to, you could do, if you go for 20 instead of 17, you would end up with t of 3 hours. Okay, it doesn't matter because these are all estimates. As long as you don't just give the dose now and you wait a few hours to give it, so it has to be at minimum 3 hours. You also don't want to wait too long, right? So if you, for example, if you had put 15 instead of 20, you would calculate a t of 12 hours. Okay, so if you wait 12 hours to give the dose, this is an estimate, so it might actually be lower than 15. So now you have gone too long with subtherapeutic levels. So what I would recommend is vancomycin. We calculated 1500 milligram IV over 1.5 hours. Gave 8 hours, give in 8 hours from now. So that way they don't give it at the time the next dose was due. They're just gonna have to wait 8 hours. And I didn't give you exact time. If in the real world situation, you would actually have an actual number for the hours. So for example, you might say, it's noon when you're calculating this, so then in 8 hours it will be 8 p.m. So you can actually order the next dose to be given at 8 p.m. or something like that. All right, this concludes this practice problem.